Dr. Innocenti, thank you very much for being with us today.
It is a pleasure.
How's the Congress?
The Congress was interesting in a beautiful venue. And I think it's remarkable that a private institution like Clinical Planas is involved in spreading knowledge in medicine. I think it's a good example.
Yeah, specialized in reconstructive surgery, but you're also well known because you started using robots in microsurgery. So for someone who doesn't exactly know the importance of that, what was the big change of using robotics in microsurgery?
Well, robots entered the clinical practice, let's say 30 years ago with the Da Vinci intuitive platform, which now is the most popular in the world. And it is a perfect device, but is not designed for microsurgery. For microsurgery, we need something smaller. So one of the engineers who has been working at Da Vinci project decided to have a startup with the aim to design a platform which is really devoted to microsurgery.
Okay. And
this was done in a very short time because only in 4 years we had the CE mark approval and we went in the clinical practice. So the advantages are that with, of course, microsurgery and particularly super microsurgery, we define super microsurgery when we work on vessel smaller than 0.5 millimeter up to 0.2, 0.3, and we have to put 5, 6 stitches. So it's a very difficult, very demanding procedure, and not very many surgeons in the world are able to do because the skill of the surgeon is all. So you might have a good know-how, you might have a good planning, good decision making, but your hands don't follow you because it's really an extreme performance. The robot can adjust this problem because with this robot we can work exactly like in a normal surgery with the fake forceps and the robotic arms copy your movement, reducing to zero the tremor. So this is the main advantage, and the indication is particularly really in super microsurgery like lymphedema surgery or this type of new application of microsurgery which are really very demanding from technical point of view.
So we've never been in surgery like that before. So what you're saying is that the actual robot mimics the movements of your hands. So you're actually doing the surgery.
Yeah, exactly.
But the robot is actually doing the incisions and the sutures and all these
things. This is so far only an anastomotic device. So it is devoted to the most difficult part of the procedure, which is connecting very small tubes with each other, vein, artery, and lymphatics. Particularly lymphatics are the most difficult because they are very small and even transparent. So it's really very difficult surgery. And but in the future, I am a clinical advisor of this company, so we are working, and they are already in the market in a few months to expand the task of the robot. So not only anastomosis, but also dissection, which is a very important part of our job. And let's see, because this is the beginning of it's the first platform done in the world. So we are really the beginning, but the potential is very good. And in the future, AI, of course, will be probably enter the scenario, and so the surgeon can stay watching in the television maybe what the robot is doing. But so far, no, this is not possible. There is still the human hand behind this. It's like the microscope. Like microscope, you know, our eyes are good, but not that good to work at this submillimetric size. So the microscope just help you, but doesn't do anything it itself. The same is with the robot for the hands. So you do the same. Like you look in the microscope, you move your hands also with the robot, but the robot do it better.
So you told me a bit about this, but what uses does it have? What clinical cases do you use?
Clinical cases is being an anastomotic device so far, and it is approved only for working in the limbs and head and neck. So now we use it to make the anastomosis, the vascular anastomosis, when we do what we call autotransplant of a tissue from a donor side to a recipient side, which need coverage. So we do that with a piece of tissue, can be skin, muscle, whatever, which has its own vascular network. So we have, when we transfer in the recipient area, exactly like we do with the heart transplant or kidney transplant, we have to reconnect the vein and the artery. And this is the job of the robot nowadays. In the future, we are going to expand the task also for us, also for the plastic surgeon. But more importantly, there are many other specialties who are now interested, because now the robot is quite well known in the scientific community. So, for example, there is a great interest by the neurosurgeon. And any specialist has different need. The neurosurgeon wants to enter from the nose to do surgery in the brain, so minimally invasive surgery. And we are thinking how to adapt the platform to the need of the neurosurgeon. The ophthalmologists also are very much interested. So I think this is just the beginning of a new era, which will not replace the human hand, of course. No, it will be never possible. But will give a lot of help, and I think this is a big advantage for the surgeon, but more importantly for the patients, because the procedures are more reliable. We demonstrated that the complication is lower.
It probably shortens the procedure in time, or
no,
not a lot?
This is not true. It's not shorter, it's more precise.
Okay, so it takes the same time, but it's
a little bit more, because we are still working on the optimal setting of the platform. We have to cover with a sterile drape. So there, with hands, you are faster, because you just go to the table of the patient with sterile gloves, and you go. So time is not true, but the advantage in quality compensates very much the little disadvantage in time.
In time, okay, great to know that. Tell me about orthoplastic surgery, which is like a new specialty. Actually, it's mixing two specialties in one.
Yes, like it has always happened like this, no? In surgery, we started from general surgery, and then the organ surgery, liver, heart, and then more and more detail, no? This is the destiny of surgery. And now, instead of sprouting a super specialized section, we are trying to fuse together two theoretical background, two different mentality. And this is very important nowadays, because there are a lot of traffic accident, there are tumor, so limb salvage philosophy is very important. With a good reconstruction team, we can salvage a lot of limbs, either traumatic or oncological. Now we have, unfortunately, a couple of war very close to us, with an incredible need of orthoplastic approach in the reconstruction. I've been in Ukraine a couple of times, and the situation is really very difficult. And all these patients need exactly the two specialties together. But the decision making must take into account both background. So the the mistake is to have the orthopedic surgeon who puts some screws in the bone, then the orthopedic surgeon goes away and arrives the plastic surgeon to cover. This is not orthoplastic surgery. It must be a joint decision, possibly to stay all together until the end of the procedure, and we must understand the need of the other specialist and try to find a common point of and it is now we are working on it. It's difficult to teach because we often make the mistake to teach something orthopedic and something plastic. We should teach something orthoplastic altogether, no? So we have started to find the right way to teach this. Probably we should start from a case discussion, because when we have a difficult case to analyze, this is the best occasion where the brainstorming, principle of the two specialties come up, and you can try to give some theoretical weight to this also.
You have to compensate also the balance between the aesthetics and the function when you're doing this.
Exactly.
What do you consider more important? The function, probably. But aesthetics is also very important in this life.
This is a very good point. It's something that I always show in my slides. And yes, in microsurgery, reconstructing microsurgery was born, let's say, 40 years ago, 45 years ago. And at the beginning, it was considered an extreme procedure to be used when the conventional technique were not able to solve a problem. So it was enough to fill the hole in some way with vascularized tissue.
Fill the hole, exactly, in any way possible, no?
But nowadays, the technique is so refined that we must give also a good cosmetic result, not only in the recipient area, but also in the donor site. So we are taking a lot of attention also in the donor side, because we cannot leave a hole where we have been harvested something. So it's absolutely true. Function and aesthetics, by the way, they always go together.
They go together.
If you have a good aesthetics, you have also a very good function, and then the opposite is true.
What's the most challenging case you've worked in that you like to talk about and you say, well, I'm really especially proud about this?
The most challenging, maybe it has been also the most recent, because if I go back, I have a long history.
Oh, I mean, probably the most challenging is always the first one, but other than that...
No, the last one. The last one was a very interesting case, because it was very difficult with the involvement of vascular surgeon, kidney surgeon, urologist, spine surgeon, and us.
Wow.
So it was a poor patient with a huge chordoma. Chordoma is a malignant tumor, which is in her case was located in the distal part of the spine, so involving almost all the lumbar vertebra, and the tumor was expanding in the abdomen. So the aorta was completely involved in the tumor. The left kidney was involved in the tumor. So it was, we'll say, a desperate case, because we had an anterior part of the procedure where the vascular surgeon isolated the aorta from the tumor, protected the aorta with the mesh, and the urologist followed the ureter and did the nephrectomy in the left kidney. They took 12 hours in doing this with a long incision anterior. So we are planning to go after, but the patient had a renal failure, so the anesthesiologist told us, no, we had to stop now. It was good also for us, because we should have done 20 hours surgery after 12 hours. So in the night. So the patient recovered, and after 2 weeks, we did the orthopedic, orthoplastic part of the procedure, which was very, very innovative, because we resect the spine surgeon. I work with maybe the best spine surgeon in Europe. So he did the resection of the spine, including the spinal cord, but this patient was already paraplegic because the tumor was involving the spinal cord. So he did a long resection, 5-6 space, almost all the lumbar spine. So this was done from posterior approach. Then I isolated on the recipient vessel for what I was going to do. So we closed the patient, we turned the patient in the other position. And I did, for the first time in the world, the biggest, we call them chimera flap. Chimera flap are with the multiple tissue. So in this case, there was skin, muscle, and a long piece of femur. So everything was harvested in the thigh, with only one pedicle, so only one artery and one vein. We were able to dissect all the collateral vessel, which provide the blood supply to the skin, to vasos intermedius, which is a muscle of the quadriceps, and 16 centimeter of femur, half femur. So and then we reconstruct the femur with an allograft. So we move all this stuff, which was really heavy, in the spine. We fixed the femur on the proximal and distal part of the spine. It was stable with the titanium rod, and then we did anastomosis after a very long vein graft because the recipient vessel were too far, and we revascularized everything, and it took 22 hours.
Wow. So there we go. This is what we were talking about, so concentrated in one procedure. Just to end this interview, why did you get into reconstructive surgery?
Because I feel an explorer, and this is what I like to do also in the life. I like to travel in an unusual place. And this is a real exploration. I mean, it's something where I don't like repetitive surgery, standardized surgery. I get bored very, very soon. And so this is my comfort zone, to be in a situation where you don't know exactly where you are going, but you know that in some way you will be able to solve the problem. Sometimes better, sometimes not so good, but this is why I like it, because almost any operation is a new travel, a new trip.
Okay. And mostly, I think in all the cases, patients are very grateful after the surgery.
They are. Even if they finish amputate, for example. We have amputation, of course. We have amputation. We are reconstructive, and if the patient has to be amputated, they ask that we do that. Because okay, you can go anywhere they want. So because they understand that we do our best.
Great. Doctor, thank you very much. It was a pleasure.
Pleasure.
Thanks.